them on a common daily basis, just because I only work in the hospital, so that's where these present. So here's the objectives. I don't need to read those to you. So the first thing we'll talk about is headache, because that's one of the more common presentations you'll see if you're working in an ER or in an urgent care even, or primary care doctor's office. Neurology is all about localization. Headache, the localization is actually to the meninges. As we know, the brain itself doesn't feel pain. So if you think about it this way, you can kind of work through a differential for headache. I will tell you, 92% of headaches are not dangerous. They're migraine, tension headaches, which are primary headache syndrome. But there are some dangerous causes, and you don't want to miss them, because they can be life-threatening. So meningeal stretching, so if there's increased intracranial pressure, such as a tumor, an AVM, if somebody has hydrocephalus, which, commonly people say water on the brain, that means swelling of the ventricles, or low intracranial pressure, so somebody gets a lumbar puncture and every time they sit up, they get a severe headache, or they had surgical procedure, a spine procedure, and then meningeal irritation. So this is meningitis, acute and chronic form, subarachnoid hemorrhage, which we'll talk about these things later on. Meningeal ischemia, so giant cell arteritis. Have you guys heard of that? Okay, good. And then the last one is mainly about primary headache syndromes. And then medication overuse, which is a common cause of chronic daily headaches. So the differential, so you think about primary headache syndromes, which is migraine, cluster headaches, tension headaches, migraine being the most common. Secondary headaches, where it's a manifestation of an underlying disease process, like a hemorrhage, a brain tumor, meningitis, all those things we talked about. So red flags, these are some things that you got to think about if somebody has the first or the most severe headache of their life. Obviously, you're probably going to want to get some imaging in an emergency room setting, not order an MRI for a week later. This is an emergency that you would send somebody to the ER if they came into your office. Abrupt onset headache, so it comes on very rapidly. Now, you have to be a good history taker, though, because people will tell you their headache came on suddenly, but you got to clarify what they mean by that. If they have a change in the pattern of their headaches, obviously headaches that are new in patients younger than 5, or if they're older and they have a new headache. If somebody has a new headache and they have a history of cancer or currently being treated for cancer, if they're on immunosuppression therapy, if they're on chronic steroid therapy, or if they have autoimmune disease, you want to be sure and ask additional questions to make sure you don't think they have an infection causing the headache. And then pregnancy. Headaches with when people pass out, or if they have a seizure associated with it, especially a new onset seizure. Headache is common if somebody has epilepsy and they have a seizure, they can tell you if they commonly get headaches after their seizures. Headaches that are, while people are exercising or during intercourse, those are always worrisome for aneurysm or some kind of subarachnoid hemorrhage. Or if they have persistent neurological deficits, obviously that's something that would need to be evaluated urgently. And if their neurological examination is abnormal, it'd be important to do further investigations. 5% of people who have a brain tumor or other structural neurological disorder presented with headache, but headache was not the sole symptom. So a lot of people with these that fall into that 8% of people with dangerous headaches, headache isn't going to be the only symptom. They'll have weakness, they'll have visual changes, or other symptoms. So this is the first secondary headache syndrome we'll talk about, which is pseudotumor cerebri, which is idiopathic intracranial hypertension. This is common in females, especially women that have gained weight due to some fluid changes. Headache is the most common symptom of this syndrome. This kind of headache is due to increased pressure, so it will be worse with Valsalva or exertion. When they bend over to tie their shoes, sometimes their vision will black out. The most important thing in this syndrome is you got to look in the eyes, because that's what's going to tell you if they have this or not, because they'll have disc edema. The age of onset is usually between 21 and 34. And the transient visual obscurations, that's what I was talking about, where their vision kind of blacks out during like Valsalva, during when they bend over to tie their shoe. A lot of them will complain of tinnitus. And again, the most important thing is to do a good ophthalmologic examination. To look at the backs of their eyes. So this is a normal optic disc. The blood vessels, you can make them out very easily. And this is what papilledema looks like. Obviously, the blood vessels are very blurred. The cup to disc ratio is blurred. Where in the past image, you can see the outline of the cup and the optic nerve head coming through. So here's a case presentation. This is a 32-year-old obese woman, presents with a history of daily headaches for 3 months. She has also noted brief blackouts of vision in either eye every time she bends over to tie her shoes. For the past month, she has noticed a pulsatile whooshing sound in her right ear. Her neurological exam is normal with the exception of elevated optic discs with a few hemorrhages. She had visual fields performed at her optometrist office, which were normal. MRI of the brain is normal. So what's the next thing we do? So this is kind of a presentation of this syndrome. So we'll do a lumbar puncture, because that's how you measure the pressure inside of the skull. And you'll expect the pressure to be 25 millimeters of mercury of water. And how you check the pressure is you have them lay in the lateral decubitus position, and you have to tell them to straighten out their legs. Because when you're doing the lumbar puncture, you'll have them curled up. But when you're measuring the opening pressure with the manometer, you'll have them straighten out their legs. And then obviously you'll send the CSF off to rule out other conditions, inflammatory conditions, autoimmune conditions, infections that could mimic this. Chronic meningitis. So these are the criteria for the diagnosis of idiopathic intracranial hypertension. I'm not going to read these to you, but they were all on that previous slide. So the most important thing is to get a good history and physical. These aren't going to be women presenting with the worst headache of their life. It's just going to be a new persistent headache. Remember, that's one of those red flag things, a daily headache for 3 months. They're having visual changes. So young women with headache, you need to ask about weight gain and those important questions so you can suspect this condition. And if you're not sure if somebody has disc edema, you're not able to get it, go ahead.
Is there a certain amount of weight that we're talking about? Are we talking
no, there's not a
pounds, or?
defined weight,
Okay.
but it's usually going to be 15, 20 pounds. But if for some reason, because I don't dilate people's eyes, you're probably not going to dilate people's eyes in your office. So if you can't get a good view of the optic disc, but you're concerned about this, it's important to get them to see an ophthalmologist or a neurologist, whoever can see them the soonest probably, and let them know that you're suspecting this. You'll get an MRI and an MRV, because you want to rule out a venous thrombosis as well. And you would do the MRI and the MRV before you would do the lumbar puncture, because you can't, if you do the LP prior, and then it's not really consistent with the idiopathic intracranial hypertension. You do the MRV and you've just done a lumbar puncture and you find out they have a clot, venous thrombosis, you can't start them on anticoagulation right away safely without risking an epidural hematoma from the lumbar puncture site. We talked about how to measure the pressure. This is the treatment, cetazolamide. You'll give them 1 to 2 grams daily. Usually I would have them see the ophthalmologist or the neuro-ophthalmologist prior to starting this. And there's some surgical procedures that can be done if the medication isn't able to manage the condition. And also, the condition can be cured with weight loss. Giant cell arteritis. This is usually a new chronic daily headache after the age of 50, but really this is a disease of people in their sometimes 70s, but usually 80s, and if they make it to their 90s, the older you get, the more, the higher your risk is for this condition. It is very rare to see it in someone in their 50s, but it has been documented. Typically they'll have temporal tenderness, jaw claudication, so you ask them about if they developed any worsening pain when they're eating. And then polymyalgia rheumatica is a condition that sometimes coexists with giant cell arteritis. Typically they'll have systemic symptoms such as fever and night sweats, weight loss. And then if it starts to affect vision, this is the most dangerous symptom that we worry about in this condition, is monocular vision loss, because usually it's not reversible. Occasionally it can cause a stroke or a heart attack. Typically on the lab values you'll see anemia, kind of a non-specific anemia, normocytic, normochromic usually, and then you'll see elevated platelets and increased ESR and CRP. That's the hallmark of this syndrome, is elevated ESR and CRP. Usually the ESR is greater than 100. That's like the maximum an ESR is measured. There's not very many things that cause an ESR greater than 100. Basically it's endocarditis and this condition. And those, they present very differently. If you draw an ESR and it's elevated, you would start them, and you suspect this condition, you would start them on prednisone, 60 to 80 milligrams. If there is visual symptoms, or they're complaining of occasionally losing their vision, you would want to give them high-dose IV methylprednisolone, 1 gram daily for 5 days, and then put them on oral steroids. The biopsy needs to be done usually, preferably within 1 week to 2 weeks of starting the steroids. Doctors that can do the biopsy are usually ophthalmologists, specifically neuro-ophthalmologists. So at Dean McGee here in Oklahoma City, if you're practicing here. It says neurosurgeon, but actually I've never used neurosurgeon for this. A general surgeon can do it. And then you'll taper the steroids over time, but that will usually be managed by a neuro-ophthalmologist. Subarachnoid hemorrhage. So Common presentation of this is going to be sudden onset of the worst headache of my life. They'll typically have nausea and vomiting. They'll be sensitive to light and sound. Occasionally they'll have transient loss of consciousness, neck pain, nuchal rigidity. About 10 to 25% will have a seizure. So if somebody presents with a sudden onset of the worst headache of your life, hopefully they're in an emergency room setting, you would get a stat CT scan of the head. Not unreasonable to get a CT angiogram with it, which is looks at the vascular tree. And check typical blood work. Obviously you want to get a coag panel, know what their INR is, especially if they're on Coumadin. But a lot of times in the emergency room setting, you don't know what medications these patients are on. And you do an LP if you have a high suspicion and the CAT scan is negative. But modern day CAT scans, at least in major hospitals, are very sensitive for picking up subarachnoid hemorrhage or blood. So, but the textbooks say about only 92% of CAT scans are positive, so 8% can be negative. I think that number is much higher now, meaning that CAT scans are like 99% sensitive. This is a dangerous condition though, so you don't want to miss it. And then you'd obviously get an EKG as well. Treatment is stabilize the patient and then get them to a center that has neurosurgery and neurointervention to intervene on the aneurysm and to be monitored closely in the ICU setting because these patients can develop vasospasm and it's important to monitor that frequently. And vasospasm can lead to further damage to the brain, ischemic stroke, secondary to the aneurysm. We'll use osmotic agents to decrease the intracranial pressure, so mannitol or hypertonic saline, so 3% or sometimes 21%. But that would be decided in a neuro-ICU setting. Nematop is a calcium channel blocker that's specifically used for vasospasm or to prevent vasospasm. If they do present with seizures, you do want to treat these urgently. So you would load them with an anti-epileptic medication. So Cerebix is Dilantin or fosphenytoin, Keppra, valproic acid, and those are the loading doses of those medicines. And then obviously you would use benzos as well if they're presenting and still, having ongoing seizures, which we'll talk about that later. Thunderclap headache, sudden onset of the worst headache of my life. The most common cause of this is subarachnoid hemorrhage, but there are other conditions that can do this. Intracranial hemorrhage, so due to hypertension or other causes such as cerebral venous sinus thrombosis, vertebral dissection, if they have severe onset of extremely high blood pressures, because maybe they're a dialysis patient. We see this condition called PRES, which stands for posterior reversible encephalopathy syndrome. Low CSF pressure, again, that's more common after a lumbar puncture if somebody's had spine surgery. And then there's this other condition called RCVS, or reversible cerebral vasoconstrictive syndrome, which is typically caused by medications or illicit drug use, cocaine, methamphetamines, and it causes vasoconstriction of multiple cerebral arteries, and it can lead to ischemia or damage to the brain. And then people with functional disorders, but that would be a diagnosis of exclusion. That would not be the first thing on your list in an ER setting. So primary headache disorders in the emergency room, these are very common. Migraine commonly presents to the ER. Headache is pain in the head. Migraine is a syndrome of episodic brain dysfunction with systemic manifestations, which includes headache, but not always. Migraine definition. Migraine is a genetic condition in which a person has a predisposition to suffering recurrent transient episodes, attacks of brain dysfunction with systemic manifestations that include headache is the most common symptom. The headache severity can range from mild to severe. It can be in variable locations. The classic migraine is typically on one side of the head. They can have focal neurological symptoms with migraine. It can mimic stroke and a TIA. But usually they'll have complaints of tingling that kind of travels up the arm and then travels into the face and travels down the leg. GI symptoms are common in migraine: nausea, vomiting, abdominal pain. People commonly present with chest pain. And again, in an ER setting, somebody presents with chest pain, your first diagnosis should not be migraine. But it is a common presentation. Now, if they have headache and some other of these symptoms, then you can suspect it after, but I would exclude more dangerous causes. Autonomic dysfunction. Commonly, these people that come to the ER with migraine, especially ones that mimic a stroke, their blood pressures are extremely elevated, like at the level of you see in patients that are having a stroke, 200 over 120. So you suspect they're having a stroke, and come to find out it's just a migraine. Migraines are commonly triggered. Hormonal, environmental changes, dehydration, lack of sleep. There's lots of different triggers for migraines. Certain foods, MSG is a common one. There's phases. There's a prodrome, there's the aura, the pain, and the postdrome of a migraine. So migraine treatment. Typically, you're in the ER setting, if someone's presenting to the ER with a headache, and after you've established that you think it's a migraine, typically I would recommend using IV medications if they're that severe and they're in the emergency room. And also patients with migraine that has persisted for several hours develop some gastroparesis that is not permanent, but so they don't really absorb the medications quickly if they take them by mouth. There's specific treatments of migraine, which is typically triptans and ergots. Triptans, there's multiple different kinds. These are some potential side effects. We'll go into detail on that. But triptans, the main one I want you to know in an ER setting is sumatriptan or Imitrex, because there's an injection form of this, a sub-Q injection. It works rather well. I don't see ERs use this often, probably just because they aren't comfortable with triptans. They don't know much about them, but they're safe medicines in the right patients. But if someone's presenting with focal symptoms along with their migraine, such as like numbness or tingling, or you're worried about could they also be having a stroke, but you want to treat them as a migraine as well, I wouldn't use triptans because they cause vasospasm. Then the bottom ones are some slow onset but long half-lives. Again, those are PO. Those are commonly used for, especially in females that get menstrual-related migraines. So here's the triptan. It's best if given within an hour. You can give up to 2 doses within 24 hours. 6 milligrams is the dose. Ergots, I personally don't use these very often. We just have better treatments, but occasionally for refractory patients, these are used. Ergotamine is combined with caffeine in this one. This is usually something somebody would take at home, not really that you would give in an ER. There's DHE, which occasionally we have to do for patients with refractory migraine. So there's IM formulations, IV and nasal. Again, the nasal one will occasionally be prescribed to patients. Again, these do have some side effects. They're taken chronically, they can cause fibrosis. So hydration, IV hydration is the cornerstone of migraine treatment, because a lot of times these patients are dehydrated, which is worsening their headache. And hydration is very safe in most patients. Obviously, if they have heart failure or fluid overload syndrome, you want to be careful with hydration. Magnesium sulfate IV. This is a good adjunct treatment. It's not like a primary treatment, but it's a good thing to add on to other medications you may give. So usually I'll give 1 to 2 grams infused over about 10 to 15 minutes. It's very well tolerated. I've never seen anyone develop hypotension from it. And then valproic acid is an anti-epileptic medication, but commonly used as a migraine preventative. The IV formulation of it tends to work well for acute migraine or stroke-associated headache. It works well for that as well. Typically, you'll give 500 to 1,000 milligrams, depending on the size of the patient, their tolerability of medicines. Again, it's very well tolerated, because usually you're going to give this only for a short term and not put them on it long term. Phenothiazines. Compazine is one of probably the best treatments for acute migraine. In somebody that comes into the emergency room, so you'd give 10 milligrams of IV compazine. And typically we give Benadryl along with it for 2 reasons. One, Benadryl is a sedative. And sedatives, almost all sedatives help migraine, because most people just need sleep. And then it maybe helps prevent the acute dystonic reaction that's a rare complication of compazine. If your hospital doesn't have, if you're working in rural Oklahoma and maybe they don't have compazine, Phenergan is a reasonable substitution. It's not available IV. So IM or suppository. Raglan is another antiemetic that's used in migraine. Again, it has very good data behind it. Good for women that are breastfeeding. Raglan is safe to give. 10 milligrams IV, and again, we usually give Benadryl with it. NSAIDs is another nonspecific treatment for migraine. Ketorolac is Toradol. You can give 30 milligrams IV once, and then you can repeat it every 6 hours if you need it. At 15 milligrams, Cambia is just a fancy diclofenac that comes in a powder form. It's more something that somebody would do at home. You just mix it with water and drink it. The thought is it's absorbed more quickly. Naproxen is a good medication for patients to take at home as well, which is naproxen. So you give them 500 milligrams twice a day. And it's also a good one for menstrual migraine prevention. If females know that every time they get, or they go on their cycle, that they get headaches, this is a good medicine that they can take for like a week. Maybe it started a few days prior. I don't do this often, but some will give corticosteroids to somebody that has a severe migraine, or if they have what's called status migrainosus, meaning they have a headache that lasts for days and days. Give Decadron, and mainly the data behind it is that it prevents another spell of, or basically another visit to the ER in the month. It reduced the frequency of a visit in the trial, so that's why it's on here. Any questions about headache? No? Okay. So dizziness, this is a fun topic. Everybody likes to see dizzy patients. Commonly, we have an ER residency at our hospital, and so this is a common thing that the residents tell us they like to see the least, and most ER doctors like to see the least, is dizziness. So from a Dizziness isn't always neurological, and a lot of times isn't neurological, but we're commonly called on these patients. So what does the patient mean by dizziness? Do they mean that they're lightheaded? Do they mean that their room is spinning? Or do they mean that they're having trouble with balance? That's how I break dizziness down, is I try to get people into one of those three categories, because each of those categories have different pathways that you would go down initially. But you ask patients, so tell me what's going on. Oh, I'm dizzy. Okay, what do you mean? I'm just dizzy. What do you mean by being dizzy? Is the room spinning? No, I'm just dizzy. I mean, that's typically how the history goes. And so then, if they can't really tell you what dizziness means, then you try and tell them, okay, what's provoking? Is it there all the time? Does it come and go? What makes it better? Does it get worse when you move? Does it happen when you roll out of the bed in the morning? Does it happen when you look up? Do you have any other symptoms with it? Are you always standing when you get dizzy? Does it usually happen when you go from a seated position to standing? And then you ask about other symptoms, so double vision. So why would we ask about double vision and dysarthria and trouble swallowing? Why would you ask about those? I think I heard somebody say it, whisper. They're right.
You said stroke.
Yep, so posterior circulation strokes, brainstem strokes. The vestibular nuclei are in the brainstem, the cerebellum. Those are things you worry about, so you're asking to see if they have other symptoms that go along with that. Because isolated dizziness, that would be a rare presentation of stroke. It does happen, but it's uncommon. So double vision, dysarthria, dysphagia, numbness or tingling. Do they have a severe headache with it? Dizziness is a common symptom with migraine. So most important thing, if somebody presents with dizziness, is what happens when you go in to see the patient in the ER. They're in their bed, right? The nurse has already checked them in, done their vital signs, all these things. Maybe has even already drawn blood work, depending on which ER you work in. So it's important, after you take the history and when you're doing the physical, maybe at the end of the physical, is to walk the patient. You need to see these patients walk before you send them home. Because if they can't walk, they can't go home. Whether or not that means that they've had a stroke or something dangerous like that, no, but still, if you send a patient home, they go home and they break their hip, that's not a good thing. If you suspect BPPV, which is the most common cause of vertigo, to present to an ER, benign paroxysmal positional vertigo, I would do the Dix-Hallpike. So, would a patient with BPPV, when they're just sitting there talking to you, would they usually have the dizziness? No. Would they have nystagmus when they're just sitting there talking to you? Or with their eye movement, when you move their eyes? Not move their head, but with their eye movement? No, they shouldn't. People with nystagmus and vertigo, we're going to talk about here in a second, but BPPV, they should only have the nystagmus when you do the Dix-Hallpike. So orthostatic vital signs, that's a common thing that's not done. And it's important to do them correctly, so usually you have the patient lay flat, let them rest for a minute, check the blood pressure. And I just go straight to standing, stand them up, unless they can't tolerate standing. Wait a couple of minutes, then check them, look at their heart rate, if they're on the monitor, check it. And then check it again at 5 minutes. Don't just settle, oh, it's normal after they just stood. You want to check it again multiple times. So depending on what you think, you're going to order laboratory studies. Do you need imaging? Possibly. Depends on your history and exam and what you think is causing the dizziness. So is it vertigo? So what is vertigo? Vertigo is a sensation of self-motion when no self-motion is occurring, or the sensation of distorted self-motion during an otherwise normal head movement. Causes of dizziness that last seconds to hours, so BPPV, again, is a common cause of vertigo. But again, at rest, they won't have nystagmus when they're just looking at you, but when you reposition them and do the Dix-Hallpike, you should provoke a rotary nystagmus. But again, this is transient, it's fatigable. You can make it better by doing the Epley maneuver. And again, it's caused by calcium carbonate material that kind of just gets in the wrong place, gets in the semicircular canals, and it inappropriately stimulates the brainstem by sending signals to the 8th cranial nerve. So here's a case of BPPV. A 71-year-old man presented with several months of episodic spinning, lightheadedness, and imbalance. The most recent episode occurred for about 10 seconds when he got out of bed. There's a clue. He sat down and with 20 seconds felt normal again. In another episode, he was awakened from sleep with a rotational feeling. At other times, he had spinning sensation for 20 seconds while reaching into an upper cabinet. His most recent spell was of lightheadedness while standing in line at the grocery store. So, at least these spells of where he rolls over in bed, when he looks up, those really sound like BPPV. Whether or not this lightheadedness, standing in line at the grocery store, I'm not so convinced that that could be BPPV. That could be other things. He's 71. He could have 3 causes of dizziness. Dizziness is a common thing. You know, he may be on blood pressure medications, and that could certainly be causing that. So he got a cardiac workup. He got an MRI of his brain, which he probably didn't need, but people were worried that he was having TIAs. CBC, his CMP was normal. You did the neuroexam, and because you're bright PAs, you did a Dix-Hallpike, and it was positive to the left, which showed a clockwise torsional rotary nystagmus. And again, it's going to beat the side that's symptomatic. You're going to get the nystagmus beating towards that ear. You do the canalith repositioning with the Epley, and nystagmus improved. The patient felt better and was sent home. So he continued to have episodic dizziness, typically with standing. So you said, this doesn't really sound like your BPPV, and did orthostatic vital signs, and he had a significant drop in blood pressure. So here you would look at his medication list. Is he on medicines that are causing this? Is he dehydrated? Is he on diuretics that are causing volume depletion? So here are some findings suggestive of BPPV that we've already talked about. It's fatigable. They get a rotary nystagmus. Typically when you lay them back, it may not start immediately. It may happen 10, 15 seconds. So you have to be patient when you're doing the Dix-Hallpike. And again, it gets better the more you do it. So sometimes you have to Epley these people a few times before they get better. So the treatment for BPPV is the Epley maneuver, not meclizine or other antivertiginous medications, especially in 71-year-olds, because these are anticholinergic, and they will get lots of side effects from those. Then if the patient's able, you could teach them how to do the Epley maneuver at home, or teach a family member how to do it, or set them up with vestibular rehab with a physical therapist. The Epley, or there's this Brandt Darhoff. So here's the Epley maneuver. If we have time at the end, I'll demonstrate it. So here's the differentials for episodic dizziness, the first 2 being the most common, BPPV and orthostatic hypotension, syncope, panic attacks. Meniere's is one that's a rare syndrome, and migraine is also can cause episodic dizziness. And the latter 2, Meniere's and vestibular migraine, actually present very similarly. They'll have usually vertigo that lasts about 20 minutes. So less common mimics, but can be dangerous. Certainly TIA, cardiac arrhythmias, myocardial ischemia, PE, or cold GI bleeding, POs, and insulin, hypoglycemia would be the last one, is how you figure that out. So if somebody presents with acute constant dizziness, or have what I call an acute vestibular syndrome, so they have vertigo that lasts for hours and hours to maybe even days, and the vertigo is constant. It's always, all vertigo gets worse with head movement, but even when they're resting, the vertigo is present. These are patients that typically you are a little more concerned about. So these are patients that sometimes will usually get CAT scans. They'll be concerned for stroke. So let's go over how you tell the difference. So vestibular neuritis is a common presentation of this. This is probably the second most common cause of vertigo presenting to the ER. It's thought to be a viral or post-viral syndrome related to the herpes virus that causes cold sores. So obviously you want to look in the ear and make sure they don't have a breakout. The test you do for this is called the head impulse test. Have y'all ever heard of that? During your EMT, or mention that probably, but that was a long time ago. So it tests the vestibulo-ocular reflex. So if it's positive in this condition, because this condition is affecting the 8th cranial nerve, and the head impulse test is testing that nerve's function. So basically, if somebody was having a central cause of vertigo, the head impulse test would be negative. So the treatment is usually just supportive care. Occasionally, steroids can improve time to recovery. These people are pretty miserable, so usually I do put them on steroids, and I've seemingly had good luck with it. Usually I use the same dosing strategy that I would use for Bell's palsy. So the head thrust test is you have the patient relax, and you quickly tort their head to one side, but you kind of move it slowly, and then you jerk it back, and you'll see if their eyes will, and you tell them to focus on your nose, and you see if their eyes bounce back. They should be able to just keep their eyes on you. So stroke or vestibular neuritis. So in stroke, typically they'll have other focal findings. They'll have slurred speech, they'll have trouble swallowing, they'll have double vision, or they may have focal sensory or motor deficits, meaning weak on one side of their body, or weak on, or numb on one side. If they have a dissection, sometimes they'll complain of neck pain. And then you have to ask about history of manipulation, if there was any injury recently, or if they've gone to the chiropractor in the past week. In vestibular neuritis, they shouldn't have double vision. They won't have any numbness or tingling with it. The only thing, sometimes it can affect hearing. And that's called labyrinthitis, when it affects hearing. So in a stroke, their neurological examination will typically be abnormal. Typically you'd look for cerebellar findings, so when you're checking you're having them touch your finger, they won't be able to touch their finger, but you got to tell them to go slow. Some people, but it's harder when you get close. Then you can check heel to shin with them lying flat. Run their shin down the top of their leg. You want to look at their eye movements. So is their nystagmus bidirectional or unidirectional? What do I mean by that? So if you're thinking, we use these spoons. So if you're thinking, if you tell somebody, so we'll pretend I'm the patient, so look to your right. So they look to their right and their eyes go. So they're beating fast. The fast phase is how you name the nystagmus. So the fast, the one you're seeing. So then you tell them to look left, they're still beating to the right. So the fast phase is still to the right. That's unidirectional nystagmus. Bidirectional nystagmus is you tell them to look right, their eyes beat right, tell them to look left, their eyes beat left, fast. So bidirectional nystagmus is suggestive of a central cause of, if they have vertigo, it's suggestive of a central cause causing these symptoms. So stroke would obviously be the big concern if it was abrupt in onset. Migraine can do it well as well, and that's a central condition. So, and then in vestibular neuritis, typically they'll just have the unidirectional nystagmus, and it can be spontaneous. So again, does that make sense? The fast phase is how you name it. Unidirectional beats the same way, so it beats to the right. Either, doesn't matter which way they're looking, it beats to the right. And then bidirectional means that when they look left, maybe it beats fast left. When they look right, it beats fast right. Alrighty. And the fast phase is usually away from the lesion in vestibular neuritis. The head impulse test is normal in stroke. That's always confusing because usually we'd expect the abnormalities to be with the stroke. But again, remember what it's testing. It's testing the nerve function, which is peripheral. In stroke, sometimes they'll have what's called a skew deviation. So what does that mean? That means that, again, the spoons, somebody's eyes, they're resting, they're looking at you. The eyes are equal, they're conjugate. When they have a skew deviation, one eye will be higher than the other, is what you typically see. So one eye is higher, all right? And it can be subtle. And typically with an acute stroke in the cerebellum, they're going to have trouble walking. You get them up to walk and they're falling. Where with vestibular neuritis, they'll complain that they can't walk, but if you really coach them, they can walk well. But again, if they're elderly, or they have peripheral neuropathy, or they already have trouble walking, the vertigo is just going to make that worse, so they probably won't be able to walk. But again, if they can't walk, they need to come to the hospital regardless. And vestibular neuritis, they won't have a skew deviation because, again, it's a peripheral lesion affecting the eighth cranial nerve, which has no control over eye movements. So here's a case study. A previously healthy 50-year-old man presented with acute constant dizziness about 15 minutes after waking up in the morning. The patient reported sudden onset of vertigo that persisted since that time. He also had nausea and vomiting. He felt more comfortable lying still and had substantial worsening of the condition in any position. The patient was able to sit on the edge of the bed but needed assistance with walking. He tended to veer to the left side. Ocular motor examination revealed spontaneous right beat nystagmus of moderate intensity was present. HIT test performed revealed clear corrective saccades toward the left side. No skew deviation was identified. So based on that, do you think this is central or peripheral? Peripheral? Okay, I do too so far. So what suggests it's peripheral is his head impulse test was positive. That's again highly concordant with a peripheral lesion. And he had unidirectional nystagmus. He did have trouble walking, but again, people with vestibular neuritis can tend to veer, but he was able to walk. However, I would, it would not be wrong to get an MRI in this patient, given he was veering off to one side, to be sure. But I would think it was peripheral. And again, if we have time at the end, we'll do that. Has anyone ever showed you guys how to do the Dix Hall pipe? The ENT, okay. There's very good videos on YouTube, so if we don't get to it today, I'd highly recommend you learn how to do that. And it is, when you get out and practice, it's a billable procedure. I mean, it doesn't reimburse $100, but it's like $35 or something. So we'll talk about stroke. We talked about this a few months ago. So stroke definition: sudden onset of brain dysfunction due to blood vessel occlusion or rupture. Ischemic stroke is the most common. Hemorrhagic stroke being the second most, and subarachnoid hemorrhage. So acute ischemic stroke is focal CNS ischemia with infarction. So it can involve the cortex, the brainstem, the spinal cord, the retina. And then TIA is an episode of transient ischemia without infarction, is the new accepted definition. That definition has changed over time. Typically, most people with a TIA, they have symptoms only for a few minutes, maybe 5 to 20 minutes. A classic thing is a patient says that all of a sudden their vision blacked out in one eye. It felt like a curtain was going over their eye. What is that called? What's the fancy term for that?
Emerosis fugax.
Yeah, that's correct. So usually in those patients, you want to look at their carotid arteries. So, but yes, that's a common TIA, or that's a TIA presentation. Again, it's due to a focal problem. So where is the problem at in amaurosis fugax? Where are they losing blood flow to? To their occipital lobe?
Yes.
No.
They got one right.
Is it affecting the brain? It's one eye. So no, it's at the retina. So the retina is, CNS tissue. It's due to the ophthalmic artery. It comes off the carotid. So a lot of these patients that used to be called TIAs, actually when you do an MRI scan, they have ischemia evident on MRI, but they don't have any residual symptoms. So not all transient neurological spells are due to TIA. There is a differential diagnosis. Seizure and migraine are common mimics. And there are potentially 6 possible causes of stroke and TIA. Most associated with thromboembolism. So these are the syndromes that we went over a few months ago. So left hemispheric syndromes are aphasia, right hemiparesis, or sensory loss. They can lose their vision off to one side. So when the brain is affected in regards to vision, you lose vision off to one side. It affects both eyes. You can close the right eye, they'll still have it. If they have a left hemispheric stroke, they still won't be able to see off to the right. They'll be able to see off to the left if it's affected those fibers. So that's called a homonymous hemianopsia. And then if it's affected the frontal lobe, again, they'll be looking like this, and they can't move their right side, and they'll have aphasia. So if they have a right hemispheric stroke, then the left side will be affected. They'll be neglectful of their left side, especially if the parietal lobe is affected. They'll have left hemiparesis, loss of sensation, and they won't, depending on what lobes are affected, they won't be able to see off to the left. So you got to check visual fields. And then they'll have a right gaze preference, and you'll ask them, Mr. Albertson, what's going on? Oh, nothing. And he won't be able to move the left side, so he won't even be aware. So that's called agnosia. And he's obviously having a big stroke. So almost 80 to 85% of patients always have a hemiparesis associated with their stroke, but some will only have visual changes. Some will only present with acute onset of trouble walking. So it just depends on the area of brain affected. So here's an illustration of a left hemispheric stroke. Again, he has a left gaze preference. He's hemiparetic on the right side. If you talk to him, he would have aphasia. So wouldn't be able to answer your questions or would just be talking gibberish. I couldn't find a picture of a right MCA stroke. So an anterior cerebral artery stroke, again, the most common thing is just isolated abrupt onset of left leg weakness and numbness. Occasionally they'll have personality changes. They'll be acting odd. These patients present abruptly to the ER if they have leg weakness. Occasionally, ACH strokes, if it doesn't hit the motor homunculus, they present to the ER late or they're diagnosed late because their symptoms are non-specific, cognitive changes. Left ACH stroke affects the right leg. So posterior circulation stroke, a left PCA stroke, again, that supplies the occipital lobe and the thalamus. So again, if it's left-sided, you're going to have a right homonymous hemianopsia. They'll typically have a nomic aphasia. What does that mean? That means that they have trouble naming things. So part of the NIH stroke scale is them naming objects. They won't be able to read. So again, part of that NIH stroke scale, which is the assessment you do of acute strokes in the ER, is reading. They won't be able to read the sentences. And then commonly they'll have a right hemisensory deficit because of the thalamic involvement. And then the right PCA stroke is typically doesn't affect language because language is in the left hemisphere, but they'll have the visual field deficit. And these ones are typically harder to diagnose because they come in, oh, grandma's confused. Why is she confused? She couldn't find the bathroom and she's lived in that house for 50 years. And so the bathroom happens to be, when she's coming down the hallway from her bedroom, happens to be on the left side. So she just doesn't see it, walks past it, and then she gets to the end of the hallway and it's like, where am I at? And turns around and she gets to the bathroom eventually, but she keeps on going past it. But again, these right PCA strokes don't commonly present acutely to the hospital. It's usually they've been going on for a couple of days by the time they get there. Vertebrobasilar distribution, so these are strokes that will present with acute onset of dizziness, but usually vertigo is what they will say. They'll have nausea, diplopia, quadriparesis, brainstem strokes. The thing to think about for tests, boards, etc., is crossed findings. What does that mean? Crossed findings mean a patient presents with double vision and you know that they have an oculomotor nerve palsy in their left eye and they're hemiparetic on the right. That's what that means. So they have a crossed cranial nerve finding with the body. So ipsilateral face, contralateral body. There's multiple different named syndromes, but that's the most important thing to remember about the brainstem. Brainstem can occasionally cause quadriparesis because they have a big embolus to their basilar artery and include all those penetrators that come off the basilar into the pons. So these strokes, again, can be sometimes difficult to diagnose. Not as easy as ones that present with their head over, they can't move their left side and they're aphasic. So anytime somebody has abrupt onset of trouble walking, like they can't walk, and you do a tox screen and they're not drunk or have drugs in their system, you need to think about a posterior circulation stroke. So brainstem, cerebellum. So here's the arterial supply. So small vessel syndromes, this is those deep penetrating arteries. So usually they'll have a pure motor syndrome, and that can localize to the internal